Hi, this is Dr. Poole, and this presentation is about the pathology of fetal hydrops. Fetal hydrops, or if you prefer the Latin hydrops fetalis, refers to the excessive accumulation of fluid in at least two serous cavities or body tissues. It is important to recognize that hydrops is a sign of disease, rather than being a specific disease in its own right. Until about 40 years ago, hemolytic anemia caused by Rh blood group incompatibility between mother and fetus, or immune hydrops, was the most common cause. Prophylactic administration of Rh immune globulin during pregnancy and at delivery have drastically reduced the incidence of immune hydrops. So causes of non-immune hydrops have emerged as the main causes of fetal hydrops now. Immune hydrops describes the process of maternal sensitization to a fetal red blood cell antigen, followed by transplacental passage of circulating maternal IgG antibody and fetal red blood cell hemolysis, causing severe fetal anemia. In most cases, this is due to Rhd and is commonly referred to as positive or negative when we talk about people's blood groups, for example, A positive or B negative. The severity of the hemolytic process is variable and is primarily dependent on the antibody involved and the antibody load. The fetus initially compensates by increasing extramedullary erythropoiesis, which can often be demonstrated sonographically as there is hepatosplenomegaly. Once the hemoglobin falls below 7 grams per dl, the fetus fails to maintain tissue oxygenation through an increase in cardiac output and becomes acidotic. Cardiac failure and death can follow. The degradation of hemoglobin results in increased levels of bilirubin, which can result in jaundice and even kernicterus. As mentioned, maternal sensitization to a fetal red blood cell antigen is followed by transplacental passage of the circulating maternal antibody and attachment of the antibody to the fetal red blood cell containing the corresponding antigen, which results in hemolysis and severe fetal anemia. The severity is primarily dependent on the antibody involved and the antibody load, which we measure in the laboratory by its titer. The three major causes of non-immune hydrops include cardiovascular defects, chromosomal anomalies, and fetal anemia. Chromosomal abnormalities account for a significant proportion of cases of hydrops, with a prevalence of 11 to 33% in second trimester series. The commonest association is with Turner's syndrome, reported in up to 15% of cases. There is a significant association between 45X, cystic hygroma, or a webbed neck, and coarctation of the aorta. In addition to a strong association with chromosomal abnormalities, a significant proportion of fetuses with non-immune hydrops will have an underlying genetic disorder. Skeletal dysplasias, neuromuscular disorders, and inborn errors of metabolism are the most common genetic causes that have been described with hydrops, but a wide variety of other disorders have been documented in isolated case reports but have a low prevalence. Identifying the underlying etiology is important not only with respect to treatment options, but also when considering the risk of recurrence in future pregnancies. Dysmorphic features are difficult to detect prenatally, and consequently, the diagnosis of a genetic syndrome involves involvement of a clinical geneticist, which may improve diagnostic accuracy and prevent omission of relevant investigations. Approximately a quarter of the cases of non-immune hydrops seen today have an underlying cardiac or vascular anomaly, the commonest being cardiac arrhythmias. Many different types of structural cardiac defects have been associated with fetal hydrops. Although they may not be causative, a mechanism for the development of hydrops can often be described. Although the proportion of cases of hydrops related to immune disease has decreased, hematological diseases have remained important and are responsible for a significant proportion of non-immune cases. From the perspective of underlying pathophysiology, the common final pathway is normally fetal anemia, which results either from an increased loss of erythrocytes by either hemolysis or hemorrhage, or from a reduction in red cell synthesis. Anemia may cause hydrops either directly, due to capillary and tissue hypoxia with extravasation of protein, or by compensatory mechanisms, resulting in high output cardiac failure. Hematologic causes of hydrops include red blood cell loss, which may either be due to an intrinsic defect of the erythrocyte, including hemoglobinopathies, enzymopathies, or membrane defects called membranopathies, or may be due to hemorrhage, such as fetal maternal hemorrhage or twin-twin transfusion syndrome. Another hematologic cause is decreased red blood cell production, which may result from fetal leukemia or a congenital dyserythropoiesis, another form of dysplasia. Non-immune fetal hydrops may be discovered incidentally during prenatal sonography performed for standard obstetric indications, during a workup for decreased fetal movement, or abnormal results on antepartum fetal surveillance, during a workup for uterine size greater than dates, or during monitoring of fetuses with, or at risk for, disorders associated with hydrops. Fetal hydrops is defined by the fetal findings. 2 or more of the following findings should be present on ultrasound examination. Ascites. In its earliest stage, fetal ascites appears as a rim of echolucent fluid just inside the abdominal wall, or surrounding the bladder or liver. If there is a large amount of ascites, the bowel may be compressed. Pleural effusions. Pleural effusions appear as a rim of echolucent fluid just inside the chest wall, outlining the lungs. Note that the effusion may be unilateral or bilateral and may compress lung tissue, resulting in hypoplasia. Pericardial effusions. Pericardial effusions similarly appear as a rim of echolucent fluid surrounding the heart. And finally, skin edema. Skin edema, though, is a late sign of fetal hydrops. Pathologic skin edema has been defined as subcutaneous tissue thickness on the chest or scalp greater than 5 millimeters. In hydrops associated with fetal anemia, both fetus and placenta are characteristically pale. In most cases, the liver and spleen are enlarged from cardiac failure and congestion. Additionally, the bone marrow demonstrates compensatory hyperplasia of erythroid precursors, with the exception being parvovirus-associated red cell aplasia. Extramedullary hematopoiesis is present in the liver, spleen, and lymph nodes, and sometimes in other tissues, such as the kidneys, lungs, and even the heart. The increased hematopoietic activity accounts for the presence of large numbers of immature red cells in the peripheral circulation, which includes reticulocytes, normoblasts, and erythroblasts. This peripheral blood smear picture is referred to as erythroblastosis fetalis. Again, hydrops is most commonly diagnosed during ultrasound examination of the fetus through the recognition of a collection of fluid in 2 or more cavities, including the abdomen, as indicated by the blue arrow, thorax, either pleural or pericardial effusions, which you can see a narrow rim around the heart and lungs above the diaphragm here, or the skin or subcutaneous edema, as indicated by the red circles. This is a sagittal section of fetus on MR. On the image on the left, there's generalized accumulation of fluid in the fetus. On the right, fluid accumulation is particularly prominent in the soft tissues of the neck, and this condition has been termed cystic hygroma. Cystic hygromas are characteristically seen, but not limited to, constitutional chromosomal abnormalities, such as 45X or Turner syndrome karyotypes. This is an example of immune fetal hydrops due to Rh incompatibility. Note the overall pallor, especially over the face, hands, and legs. This image shows a similar type of morphology, but from a different cause, non-immune fetal hydrops due to fetal anemia from parvovirus B19 infection. Again, note the marked pallor over the extremities. This image also demonstrates the characteristic pallor seen in fetal hydrops that's due to fetal anemia. These are sections crossways of the placenta. This is a section of liver which shows the sinusoids containing numerous nucleated red blood cells and other immature marrow cells as an example of extramedullary hematopoiesis. This demonstrates the peripheral blood smear appearance of erythroblastosis fetalis, which refers to the presence in the circulation of large numbers of immature red cells, including reticulocytes, normoblasts, and erythroblasts, in the setting of hydrops due to fetal anemia. Now, I believe I talked about this in the Brain Behavior and Cognition course, but this is just a review of kernicterus that is seen in fetal hydrops. The affected brain is enlarged and edematous and has a bright yellow color, especially involving the basal ganglia, thalamus, cerebellum, cerebral gray matter, and spinal cord. So to review, fetal hydrops is the accumulation of excessive amounts of fluid in at least 2 serous cavities or in the body tissues during intrauterine growth. There are immune and non-immune causes. Rh incompatibility is the most common immune cause, while cardiovascular defects, chromosomal abnormalities, and non-immune causes of fetal anemia make up the bulk of non-immune causes of fetal hydrops. Characteristically, in hydrops due to anemia, the placenta is diffusely pale. The fetuses show generalized edema. If there's sufficient hemolysis, this can result in hyperbilirubinemia, and the patients appear jaundiced and may have brain abnormalities characterized by kernicterus. Microscopically, we can see extramedullary hematopoiesis, particularly in the spleen and liver, and the peripheral blood smear shows erythroblastosis, meaning immature red blood cell forms in the peripheral blood.